Okay, good morning, everybody. So this morning I wanted to talk about one of the more difficult diagnoses that we deal with here with pediatric neurosurgery, less commonly in the adult population. But it's really talking about the intersect of neurosurgery with Dipg. And this is something that Mark Swedane, who's at Columbia Cornell, has really spent his whole career talking about. And I think it's an important it's an important thing to talk about, mainly because of also the ethical considerations as to how to treat these children. We see about 10 to 15 of these kids a year, and they are the least. They are just very difficult conversations to have with these parents because there's not much we can do for these kids, and uniformly it's terminal. So Dipg really continues to be a major therapeutic challenge. No significant improvement in survival has been accomplished over several decades, despite the incorporation of proven therapeutic strategies in other pediatric CNS tumors. There's a median survival of really less than 12 months. So this is the GBM of pediatrics. Dipg remains the leading cause of brain tumor death in the pediatric population. It's the #1 cause of death in children with cancer and the #1 cause of death in children. Over the past 75 years, the neurosurgical intersect with Dipg has really been characterized by a fluctuating process governed by surgical intent and counterbalanced by feasibility. Because as we all know, the pontine segment of the brainstem has rightfully been recognized as a domain that is fairly intolerant to surgery, especially in these children who already have issues. All right, so this is a picture of a child who presented to us when she was 4 years old. This is an uncommon picture in the sense that this child had some speech delay at 4 years old. The neurologist ordered an MRI scan of the brain, and this was found incidentally. The classic triad of these children with Dipg is that they present with cerebellar signs and symptoms, dysmetria. They present with long tract findings, as well as cranial neuropathies. This child presented with speech delay, none of the classic symptoms. And generally, how we diagnose these tumors, mainly based on the advent of MRI, was radiographic imaging, where you have the abnormality confined to the pontine region. And then typically, initially, there's no extension to the medulla or the midbrain. Now, rightfully so, these have been termed now, previously we called these diffuse infiltrating pontine gliomas. Now the proper name for them are diffuse midline gliomas, so diffuse high-grade midline gliomas. So it's all semantics, but it's an important semantic to distinguish between, because these parents will hold on to every word that you say. And so you need to say the right diagnosis and the right semantics, or they lose. They definitely are very hung up on that, which is understandable. So really, multimodal treatment approaches have significantly contributed to improved survival in children with CNS tumors. So generally, the majority of the tumors that we treat, posterior fossa tumors, with the exception of AT, RT, and Atanters, you have 70% survivability. However, these, again, like I said, they have a dismal prognosis. The discordance in the progress of therapeutic benefit continues to really frustrate all of us, which is why this is part of this talk, is talking about how we're progressing and what lengths we should continue to go to for these children. So these tumors are prevalent across the entire age spectrum. However, they occur predominantly in the pediatric population, accounting for 13.3% of all primary CNS tumors in the age group of 0 to 14 years. There's a peak incidence within a relatively narrow range between 5 and 10 years, and without any gender predilection. So about 90% of brainstem tumors are gliomas. The other 10% can be, we've also seen PNETs as well. And in children, the large majority of Dipgs, they're accounting for 80% of all brainstem gliomas. This is about 200 to 300 cases per year. And that's another reason why a lot of research has not gone into this, and a lot of funding has not gone into this. You look at the dichotomy between the amount of money that goes into breast cancer, prostate cancer research, and high-grade midline glioma, and there's a marked difference in the resources. So I'm going to circle back to this picture by the end of the talk, but here you have a 4-year-old girl, no symptoms other than speech delay. And the question is, what do we do? How do you counsel the family? And what are the clinical trials? What are the treatments that we can give? And we'll talk about that. So she survived the longest that I've seen any child survive. She survived 4 years, mainly because she did not present symptomatically initially, and it was incidentally found. But unfortunately, the overall trajectory and the endpoint is the same for these children. So what is the right treatment? So due to the significant infiltration of the brainstem, the standard of care right now for these children is really local irradiation. It's a total dose of 54 to 60 gray when they're symptomatic, and that's important to talk about. So it's conventionally fractionated radiation therapy. It's 54 gray at 1.8 gray per fraction. It's the standard treatment for patients. 10% of these children present with hydrocephalus, not all of them, but it's something that we need to keep a close eye on, especially as they're going through radiation treatment and any of these other clinical trials, and we'll talk more about that. Then you have to talk about tissue sampling. So to date, we have not seen any benefit with any tissue sampling. However, it's given us more information as to how to deal with these kids in the sense of through clinical trials. So this helps with diagnosis, not only histologically, but with molecular tumor profiling. And then the clinical trials currently, so I went and looked this up last night. Overall, there have been over 250 clinical trials. Some have closed, some continue to be active, but there are currently 43 active clinical trials that are enrolling patients as of last night. So this is a classic appearance of the basilar artery being overtaken and really engulfed by this DIPG. There tend to be hyper intense on T2 and flare, hypo intense on T1, and oftentimes they are contrast enhancing and they look aggressive based on the contrast enhancement profiling. So here's some DIPG target volumes. So the majority of patients show transient clinical improvement and extended survival of approximately 3 months in response to radiation and steroid treatment. We also give steroids to these kids because of the other symptoms that they have and the overall edema that they develop from the radiation. Unfortunately, when you first meet these kids, and then when you see them by the end of their radiation treatment, we've created a very Cushingoid child who looks nothing like the child you initially met. And it's, you see it enough times, and this is a diagnosis we all hate to encounter because it's just very depressing for all of us. So, unfortunately, no survival benefit has been demonstrated with the administration of radiosensitizing agents. There have been clinical trials that have looked to that, or increased radiation doses up to 78 gray. I think all you do there is, and it's been documented that all you do is you increase the toxicity of the treatment and you worsen the overall cranial neuropathies and other findings that you see. So these DIPG patients commonly present with clinical or radiographic tumor progression approximately 3 to 8 months after completion of radiotherapy. And many patients receive adjuvant chemotherapy within a clinical trial at this time. However, no neoadjuvant chemotherapeutic agent or high-dose chemotherapy with stem cell rescue, which we often use for the round blue cell tumors, ATRTs, ependymomas. I'll take ependymoma out, but the medulloblastomas, that in them has shown survival benefit. In these kids has not shown survival benefit at all. So no survival advantages have been seen with hyperfractionated, hypofractionated, addition of radiosensitizers, brachytherapy boost, stereotactic radiosurgery boost. And you can also consider hypofractionated schedules at 3 gray per treatment dose, and that decreases the treatment to approximately 2.5 weeks as opposed to 6 weeks. which in some of these kids, because they're not close to these radiation treatment centers, it's a long drive for them, and it can become difficult in terms of life and how these parents get down here. So Tinkle et al., this is a recent article that talks about symptom burden after radiation therapy. So it was a retrospective review of about 108 patients with newly diagnosed DIPG treated with conventionally fractionated radiotherapy from 2006 to 14 at St. Jude's. The presence and severity of neurologic symptoms related to cranial neuropathy, cerebellar symptoms, and lung tract signs were reviewed before and weekly during radiation therapy. So the median dose to the first sign of symptomatic improvement was 16.2 gray for cranial neuropathy, 19.8 gray for the long tract findings, and 21.6 gray for cerebellar findings. And most patients showed improvement. What does that mean? That means that if these patients are symptomatic, by the time they're halfway through their radiation dose in radiation treatment at the 6-week point, they should be feeling a little bit better. It's important because the parents want to know when is their child going to feel better? When are things going to improve? Patients without any improvement in cranial neuropathies experienced a modest improvement in progression-free survival and overall survival, and the low cumulative radiation treatment doses resulted in neurological improvement in most patients in the DIPG. And I say most patients because we've all had patients where they get a little bit worse and they continue to be worse because they've presented far too late in the process. And during the pandemic, with a lot of the telemedicine visits that were occurring in the community, we saw an uptick in these children coming to us late in the game. Specifically, they would present with some sort of cranial neuropathy in relation to a 6 nerve palsy, something along those lines. With some ataxia, they'd be seen by a nurse practitioner, they'd be sent to an optometrist, then the optometrist would do some treatment, see that their eye findings were worsening, but this was also via telemedicine. And then eventually, a month or 2 months later, they would see the neurologist. At this point, they'd fairly farly progressed into the treatment, and then they arrive at our doorstep fairly debilitated. And in those children, we see that even despite starting the radiation treatment, their symptoms don't improve very fast. And it's heartbreaking to talk to these families and these patients. So again, this is just a chart demonstrating what was said. So there's been an 85% improvement in the cranial neuropathies at the end of radiation therapy, where 95% of those patients had cranial neuropathies. 77% of patients had long tract findings, and after radiation therapy, 80% improved. And then in cerebellar signs, 72% had it with 87.9% improvement. And it's important that we are very clear with the parents, because again, they're going to say, well, how come she's not improving or he's not improving? And this is there's a great deal of distress related to this, and when their child is going to improve, be able to walk again, their face be more symmetric, their eyes be better. So reirradiation, and we've done this on a number of occasions. So given that symptom burden is improved early during radiation therapy, low dose reirradiation may provide some symptomatic benefit at recurrence. They all have this honeymoon period where they get better for a couple of months and then they deteriorate even further. So Janssens et al. In 2017 reported that 31 DIPG patients ages 2 to 16 treated with reirradiation with a median of 20 gray had a median overall survival benefit of 3.4 months compared to 39 case matched controls who did not receive reirradiation. 24 of 31 experienced clinical stabilization or symptomatic improvement with no significant toxicities. However, I think what's most important to think about here is also the quality of life, because what does clinical stabilization and symptomatic improvement mean in these children when they're fairly debilitated along the way? So the prognosis, unfortunately, is poor and unchanged. Again, 11 months survival, 1 year survival, 42.3%. 2-year survival is 9.6%. There's no improvement with the addition of any other treatments. And again, that's why part of the reason why I wanted to talk about this today. I touched upon this last year about the molecular profiling. However, so I can say that when I was a fellow 11 years ago, we were offering biopsy to everybody. And the main rationale for that was it was not done on a clinical trial, first of all. And the main rationale was, well, if these were found to be PNET related or small blue cell tumors versus the glioma, would there be a difference in the survival? The answer to that was no, but we now we know that. But and there was about 8 or 9% of those patients that had something other than a glioma, but uniformly they all progressed and the overall survival did not change. So historically, stereotactic biopsy of brainstem tumors is really an old procedure that was described by Gleason et al. And stereotactic biopsy of these patients has since been very controversial and limited to patients with atypical presentation on MRI, and more recently to patients enrolled in clinical trials at dedicated cancer centers. So right now, there are a handful of clinical trials that require biopsy in order to be enrolled in the clinical trial, and we'll delve into that a little deeper. So in 2011, Hankinson et al. Really described the controversial results of a study asking pediatric neurosurgeons to decide whether or not the MRI characteristics of selected tumors were atypical or typical. And it was found that more than 75% of the participating neurosurgeons that were in agreement of the MRI findings they're only in agreement in 43.8% of cases. So this essentially kind of opens up that the diagnosis of DIPG solely based on imaging features and a typical clinical presentation may not be sufficiently reliable as a standard of care in terms of offering biopsy to these patients. So patient stratification based on the biology and the molecular characteristics of the tumor will open the door theoretically for targeted therapy in clinical trials with the goal of improvement of overall survival in these patients. And that's really the aim as to why the stereotactic biopsy was really proponed. So this approach is scientifically rational, but it really incites a very colorful debate about the ethics of tissue sampling in these children in the absence of a recognized therapeutic value for these kids. So Nalin Gupta and this is a multi-center trial that talked about the prospective feasibility and safety assessment of surgical biopsy for patients with newly diagnosed diffuse infiltrating pontine glioma, multi-center trial. And the question was, is it feasible? And what are we going to do with that information? So subjects were eligible for the trial based on clinical features and imaging appearance. It was just any DIPG. It didn't need to be atypical presentation. 53 patients were enrolled at 23 institutions. 50 underwent biopsy. So as you can see here, as I stated before, the majority of patients who present are the 5 to 9-year-old patients. The second highest group are around the 3 to 4 year age. And then over 10, it's less common, and there's an equal distribution between gender. So these kids are fairly young presenting. No deaths were directly attributed to the biopsy procedure in the sense of nobody died immediately within a couple of days after the biopsy procedure. However, one subject died 2 weeks following the biopsy with a cause of mortality attributed to disease progression as well as intracranial hemorrhage. So this grade 4 here was intracranial hemorrhage and respiratory failure. This is the same patient, and this patient passed away. So not a benign procedure to perform. And although we all can do stereotactic biopsies, I think within the brainstem in these children who are already teetering, is a high risk to benefit ratio. And what is the benefit if we don't have proven treatment modalities? So in this study specifically, they're biopsied, and they were looking for a couple of different findings, MGMT and EGFR, and based on whether or not they're positive or negative, and you can see the 4 different really buckets they put these patients into. They were given different medication, and unfortunately, this did not confer any sort of survival benefit. So then the question is, what route do you take for the stereotactic biopsy? Do you do a transcerebellar biopsy? Do you now use a ROSA robot, Lexall frame, non-frame biopsy, or do you go transfrontal and go this route? So 2 different approaches. The majority of the children in this study were transcerebellar. But either approach has risks involved. So in 2012, there's really the first breakthrough with the biopsying of these lesions, and it was found that these children had epigenetically distinct from pediatric and adult high-grade gliomas. They're highly specific for midline astrocytomas of this H3 K27M mutation, or it's called the H3 histone, and there are several different types of those mutations, and we'll go into that in a second. 70 to about 84% of these lesions harbor a point mutation in the histone variants H3.1 and H3.3. So the first slide here where it says A, it's a classic histopathology of H&E, a staining showing the infiltrating nature. And in B, it's being stained for that H3 histone, which is the brown, showing avid positivity of that histone. So what we've seen in these children, this is very common in the midline gliomas, not only brainstem, but you also see it in the thalamus, the midbrain. And so in these kids, regardless of what the histopathology shows, for example, you may not see palisading necrosis and these sort of findings that would push it up to a grade 4, but if you do have the H3 histone marker, it automatically is considered a grade 4 with a poor prognosis, regardless of the histology under the microscope. So that's something that did come out of the biopsying and the research that was done. So this, again, has been emerged as a prevalent genetic mutation in aggressive midline gliomas. As we said, the thalamus, the pons, or the spinal cord. If these tumors are left to go long enough and these children survive long enough, you see them extending through the tracts into the thalamus as well. So beyond palliative radiation, again, nothing has been found. So these are the 3 subtypes: the H3.3 with the P53, the H3.1 mutant, the H3 wild type, and most importantly, no single case of BRAF V600E mutation has been found. And the significance of this is that some of these tumors histologically look like low-grade gliomas. However, the location as well as this histone mutation really changes the prognostic significance, as well as the fact that none of these are positive for BRAF V600E, which is found in the low-grade juvenile polycytic astrocytomas and the low-grade astrocytomas that we see. So is there a less invasive way that we can get the same answer? So liquid biopsy for this histone mutation. And so this is a recent article that came out in Nature that one of the pediatric neurosurgeons, Amanda Saratzis, who's at Northwestern and now going on to Indiana, she wanted to standardize the liquid biopsy for pediatric diffuse midline glioma using this PCR. So right now, there is no clear-cut test for liquid biopsy for this histone mutation. This is all experimental. We do send this marker. It has to get sent over to Europe. They used to do it at Children's National Medical Center, and her lab used to do it as well. But right now, this is a really unreliable form because the question is, do you take it from lumbar puncture? Do you do an external ventricular drain? Oftentimes, these children don't have external ventricular drains, and a lumbar puncture is far easier to obtain CSF than to doing an EVD, especially since only 10% of these patients develop hydrocephalus. So how do you get the fluid? And if we do get the fluid, is it reliable? And the answer is no, not as of yet. It's not reliable. They have seen that if you do get the spinal fluid from the brain, the likelihood of being positive is much higher than from the spinal fluid. But again, we're not there yet in terms of this. But this would be excellent if we could do a liquid biopsy in lieu of a stereotactic biopsy for these children who are already debilitated, in an attempt to be able to enroll them in a clinical trial. Again, a lot of these clinical trials do require tissue diagnosis stating that they are histone positive. So what are some of the clinical trials currently available to patients with DIPG? And I thought it's important to talk about these clinical trials. We're involved in one clinical trial that I spoke about last year. There's another one that will be coming up that we're going to be involved in that I'll speak about. So I won't talk about the ONC201 one that I spoke about last year. But we see about 10 to 13 patients a year with this diagnosis, not just DIPG, but midline high-grade gliomas. These parents are desperate, and they're looking for any option available to save and cure their child. And unfortunately, there's a lot of, outside of clinical trials, there's a lot of people that have set up these interesting clinics that state that they can cure their kids' cancer. And unfortunately, they require full cash payment. And it's pretty disturbing to see some of these clinics that pop up that have no scientific backing and are not involved in clinical trials. So it's something that we have to mention to our parents and steer them clear, because they're just really preying on their grief to get revenue, unfortunately. So Mark Swedane has really spent his whole career doing incredible work in regards to convection enhanced delivery. And so the basis of this is the fact that the blood-brain barrier doesn't allow enough of the chemotherapeutic agents to get to the actual tumor tissue to treat it adequately. So this was his thought process in attempting to get a higher concentration of therapeutic modality into the tumor tissue itself, and attempting to evade the blood-brain barrier to see if this would help. So this was first described in the 1990s. Chemotherapy is delivered to an interstitial space via this microcatheter under continuous low hydraulic pressure. What it creates is this high regional drug concentration in the tissue of interest. And in 2002, Mark Swedane demonstrated this in a rodent model, and then proceeded ahead with a phase 1 clinical trial demonstrating safety and feasibility with radio-labeled antibody, and which shows no dose-limiting toxicities. That trial is done. He's now on to the second trial, and we've sent several patients there. His trial does not necessarily require a biopsy. It also precludes children who have any sort of metastases. So oftentimes, if these children present late enough in the game, they develop metastases in the spine, as well as throughout the rest of the brain, and they are not eligible for, I would say, the majority of the clinical trials that are available. Also, their Karnofsky performance score has to be a certain level before they would be considered. And so if you think about all the limitations for all of these clinical trials, you really have a very small group of patients that have to present at the perfect time. This convection enhanced delivery occurs after radiation therapy. So we know that radiation therapy is the gold standard right now. So we do not delay the radiation therapy and trade it for something like convection enhanced delivery. So these children all would get their radiation therapy, they would progress. And then once they became more clinically symptomatic, then they could move forward with this convection enhanced delivery. However, if they're too debilitated, they won't be eligible. So it has to be that perfect sweet spot with these children. So he did validate that over 1,000-fold higher drug concentration was found in the intended pontine segment on these rodent models versus the rest of the body. The other treatment modality at the same institution, I believe, is Dr. Greenfeld, and I believe Heather McCrae. Dr. McCrae is working on a clinical trial, bringing it over to Jackson from her mentors up there, where they're looking at intra-arterial chemotherapy as well. So we've seen that this has been beneficial in children with retinoblastoma. And so there's clinical trials ongoing right now. And hopefully we will be a part of this once all of the paperwork goes through. But this shows essentially what you do is the basilar artery is the main area that would be feeding the pons. So it's super selective intra-arterial cerebral infusion to increase the concentration of drugs within tumors by opening the blood-brain barrier and delivering drug to target tissue during a permissive therapeutic window. And so that is really another way to subvert the blood-brain barrier. So the next up and coming thing that really John Ragab has devoted a lot of time to, as well as a former fellow of ours, is MR-focused ultrasound. Right now, there's two machines. There's a high frequency unit and a low frequency unit. We here at Children's have the high frequency unit and are involved in a clinical trial that looks at deep-seated tumors in children, generally hypothalamic hamartomas. They've enrolled 5 patients. But the high frequency unit is not the one that's being used to open the blood-brain barrier in children. So MR-focused ultrasound with a low frequency unit is a really exciting new modality. And Dr. Rutka at Toronto has really put in a lot of the groundwork for the rodent models showing the blood-brain barrier disruption with this. So as we all know, as based on the convection enhanced delivery clinical trials, as well as the intra-arterial chemotherapy clinical trials, the blood-brain barrier prevents most of these drug therapies from reaching the brain. So the thought process was these low-intensity pulsed ultrasound sonication of the brainstem with these systemic microbubbles can open the blood-brain barrier. So essentially, delivery of these targeted ultrasonic waves causes an interaction between the administered microbubbles and the capillary bed, resulting in this enhanced vessel permeability. So what Dr. Rutka found was opening of the blood-brain barrier with ultrasound is safe, it's localized, and it's reversible. However, the results last for about 5 hours. So what does that mean? That means that you can sonicate the brainstem safely, but the medication would only be at the highest dose for those 5 hours. So if you needed to do this several days in a row or several weeks in a row, it would require multiple sonication events. So a large panel of therapeutic agents can be delivered to the brain with ultrasound, and extracranial implantable ultrasound devices are currently in clinical trial right now. There's one in New York where there is a clinical trial ongoing with a different engineered focused ultrasound unit that is not part of Insightec. I am currently involved with collaborating with Baptist and Mike McDermott as they have the low frequency unit. It's an expensive unit, and to start a clinical trial for these children where concurrent with radiation therapy, we would give the MR focused ultrasound and then also give something like panobinostat during the same time. So to have 2 arms where one is getting radiation therapy and MR-focused ultrasound. The other is getting concurrent radiation therapy and MR-focused ultrasound in addition to something like panobinostat. So it's exciting. We're still in the beginning stages of this, but I think this is a nice kind of segue into more minimally invasive findings. This is work that Dr. Rutka has done, and I'll explain what this is. This is his rat model, and again, incredible work that he's done, and really to be commended for all of this work. It's very impressive, but he would inject these rats with Evans blue. And so this is microbubble. I don't know if you guys can see my pointer, but the second row is microbubbles alone with Evans blue. The top row is just Evans blue. The third row is MR focused ultrasound with Evans blue. And the fourth row is MR focused ultrasound with microbubbles. And so what we see in this progression is seeing that microbubbles alone, once being injected with Evans blue, it just shows a tiny bit of blue come up on the brainstem. MR focused ultrasound alone without the microbubbles does not allow any Evans blue in, but the microbubbles plus the focused ultrasound in conjunction really kind of litters the brainstem with this Evans blue, showing that this does open the blood-brain barrier in this region. This was then confirmed with MRI that showed contrast enhancement in this region in all four of these groups, excuse me, to show the difference. And then one of the other things he did was his was mainly a safety profile in the rodent model, and he monitored the breathing and the heart rate in these rats, and that was found to be safe as well. Did not affect that. So this leads us into back to the liquid biopsy. So if this would open the blood-brain barrier, the MR-focused ultrasound, the microbubbles, what about getting a liquid biopsy after treating these children with MR-focused ultrasound and microbubbles to see if we could get H3K27 or histone positivity? And again, there's a lot of unanswered questions, but again, it goes back into the ethical constraints of this. A lot of these children are very debilitated. A lot of these parents want everything done, but quality of life is so important in these kids because they have a very short period of time that deteriorate considerably, and it's something that stays with you for a long time. So now to go to the work of some of the other people, I've had a couple of patients go on and ask me about the CAR T cells, and I think I was very enthusiastic about CAR T cells, I think, initially when I heard about it. And then I saw some of the outcomes of my patients, and we'll talk about why I'm less enthusiastic about this now. So CAR T cells, we'll talk about what CAR T cells are. But essentially, CAR T cells, it's essentially using your own immune system to attack these tumors. And what we've seen is that this is a treatment modality that is used in leukemia in children. It's what is being used, whereas in these midline high-grade gliomas, this is still experimental in nature. So it's been shown to be promising in mouse models, including the midline glioma as well as medulloblastoma. So how is this done? You remove blood cells from the patient to get the T cells. Then you have to have a lab. So right now, a lot of the more commercial labs are now doing this, as this is becoming more common. But what's better is if you have your own laboratory addressing this, so that you can kind of cut out the commercial labs, because this costs costs significant amount of money. So they make the CAR T cells in the lab, they insert the gene, and then you have this chimeric antigen receptor. They grow millions of these CAR T cells, and then what you do is you deplete the immune system by giving kind of like a bone marrow transplant treatment dose, and then you infuse these CAR T cells into the patient. And then the thought process is your CAR T cells bind to the cancer cells and kill them. And so it was found that this really has some anti-tumor efficacy on the anti-GD2 CAR T cells in these H3K27M diffuse midline gliomas. What does all this mean? This is all fancy word for saying the histone mutation has these GD2 receptors. So if you create anti-GD2 CAR T cells, they attack the H3K27M diffuse midline gliomas. Michelle Mongi at Stanford is really the pioneer of this. They're doing this right now at Stanford. They're doing it at Seattle Children's as well as Texas Children's Hospital. Without a dedicated academic center with a functional lab that is attached to you, I think it's very difficult to do this because the commercial labs, when I looked into it, it was upwards of $200,000 to engineer these CAR T cells. And then the question comes into play of, well, who pays for that and the clinical trials, et cetera. So it's very complex, especially with the setup we have here at Children's, where we're kind of in limbo between us and UM, and it becomes very complicated. So this is actually a slide from Dr. Mongi, where she talks about the treatment and monitoring plan. And again, I've sent 2 of my patients here, and I've talked to the families about their experiences. And unfortunately, there's been no survival benefit for the 2 patients that we've had. So we have, you screen for the H3K27M mutation. What does that mean? You have to have a biopsy. So stereotactic biopsy must happen. This happens after radiation therapy. So the majority of these clinical trials, as I stated before, you get the radiation therapy. They get in their honeymoon period. While they're in their honeymoon period, the parents look for all of the clinical trials. Unfortunately, it means moving yourself away from home because there are no CAR T cell clinical trials here in Florida. So you, once it's confirmed that there's this mutation, which can take upwards of 2 weeks, the CAR T cell is manufactured, and in the meantime, an Ommaya reservoir is placed. So this adds another layer. Again, as I stated before, I think I've said this now, this is the 3rd time, only 10% of these kids develop hydrocephalus as a result of aqueductal stenosis from the pons pushing. So does every child need an Ommaya pre this? No. So we're talking about now 2 different interventions for these kids who are clinically not well. So not only do they have to have a stereotactic biopsy, but now they have to have an Ommaya reservoir placed as well. We've placed Ommayas before they've left. We've also done biopsies, but again, you have to know if the parents want to be involved in a clinical trial that will require biopsy. So then once they do the CAR T cell manufacturing, they have to be admitted to the ICU. It's a multidisciplinary team that has to take care of these patients. Once the IV CAR T cells are infused, there's a 28-day intensive toxicity monitoring. And this is a fairly toxic treatment for these children. They are in the ICU for 7 to 14 days. And almost, so we had Dr. Mongi come speak at our pediatric symposium. She has 6 children that she has treated with CAR T cells just in the phase 1 right now. And then 3 children who have either brainstem tumors or the gliomas in the thalamus. So all of them develop the cytokine release syndrome. The rationale for the Ommaya is they jerry-rig an Ommaya with a butterfly needle that then gets attached to a drainage bag, because these children, due to the cytokine release syndrome, as well as the tumor inflammation associated neurotoxicity, the type 1 and the type 2 that they develop severe inflammation in the CNS structures that cause worsening of existing deficits or new deficits. So the majority, actually all 6 of these children, developed elevated ICP that needed to be treated with drainage of the spinal fluid. So here you have children who are debilitated, have already gone through radiation therapy. You put them not through 1 surgery, but now 2 surgeries. Now you've put them in the ICU for 14 days. And they're very sick for this period of time. And her results have shown that the tumor does regress a bit during this time, but overall survival has not been significantly changed. So that leads me kind of full circle back to where we are, where we started initially, where, there's not been any benefit to any clinical trials to date. Some of these clinical trials, and the majority of them, now are requiring tissue sampling, biopsy. Some are requiring Ommaya reservoir in addition to the biopsy. So the question is, what are the ethical considerations regarding treatment? And these families are desperate, and they will try any therapy offered in an attempt to cure their child. And so the question remains, you see this child who's 4 years old, presents incidentally. We didn't treat her till she became symptomatic about 2 years later. This is the longest survival that I've seen in a child. Once she became symptomatic, she got radiation therapy and then progressed very quickly within a year and passed away 4 years later from the beginning of her treatment. I'm sorry, from the time where we found out her diagnosis. I had another patient recently who presented to me. The father had just been diagnosed with ALS. He was a single child, and mom was dealing with a new ALS diagnosis in her husband, and her child was recently diagnosed with this Dipg, long tract findings, cranial neuropathies. Unfortunately, he presented in, I want to say it was May, and he passed away last month with metastatic disease and seizures as a result of his metastatic disease. So she opted for just the radiation therapy and no clinical trials. It's hard for me to recommend a clinical trial knowing what I know now, and knowing of the 14-day ICU stay with the CAR T-cell trial, the biopsy associated. So it's a very difficult place to be put in. Our one clinical trial that we have, the ONC201, requires no biopsy. It's an oral drug during radiation therapy, and I'm hopeful that we'll see some sort of benefit with the MR-focused ultrasound, which also won't require a biopsy. So I'm open to any questions you have. It's a difficult diagnosis and a very important ethical dilemma that we have. And if I never see another child with DIPG, I would be very happy, because these uniformly end fatally. But of course, we're all happy to take care of these patients.
Nice talk. I'll just make a comment and add a couple things. I completely agree. I think sort of all of us in pediatric neurosurgery, this is our least favorite diagnosis, because we see the scan and we know how devastating this is for the families, and actually for us too, caring for these patients. In terms of my IA trial, just a couple things. So the original trial was just a one-time dosing, so we didn't expect to have any efficacy. It was really a safety trial. We treated 13 patients, was completely safe. We just had a couple rashes and 2 nosebleeds, all minor, self-resolving, and one of those kids had had nosebleeds prior to enrollment, so we're not sure if it's actually related. Labs were all fine. Our survival was 17.3 months, so it is higher than historic controls, but it was a very treated population, and we didn't restrict access to other trials. I think that's one thing. Ethically, most of the trials, they undergo radiation before enrollment, and you often allow them to enroll in other trials. And then Mark's trial was ongoing while I was at Cornell. And so one other thing on that. So now we're doing repeat dosing. We have approval at Cornell. We published the first cohort this summer, and then we're trying to get it to Jackson. As Dr. Niazi mentioned, we're through the IRB. We have approval from Cornell. We're going through the Jackson IRB, and the big hiccup seems to be grants and contracts and them agreeing over terms between Cornell and So I'm hoping we can get through that, but we'll see. And then in terms of Mark's trial, it's currently on hold at the moment. They had finished up the first phase, and now they're working on the paperwork to open the second phase. And Dr. Niazi mentioned the 2 trajectories for biopsy. His trial for infusion did go supratentorially, and that was partially due to a longer track length to avoid the infusion diffusing out, and partly due to logistics of the magnet at Sloan. So.
I think the other important point here is that the majority of these children now do metastasize, and almost all of these trials exclude these children with metastases. And so unfortunately, our MR-focused ultrasound trial coming up is going to exclude metastases as well. So, these kids survive long enough, they're going to have metastases, as we've seen. And it's, the desperation of these parents it's very sad, very, very sad.
Although sadly, even if we could just get them for the phase until they metastasize, that would be an improvement from where we are now.
Yeah. And I think, your comment about the 17 months, I think that's why I showed this last scan here, right? I think it's, now we are getting MRIs for a lot more things, speech delay, these things. To say that speech delay is not 100% related to this, I don't think anybody can really, really say that. There is a reason they are getting an MRI. And so I think if you pick it up early enough, you do see a significant trajectory in terms of the survivability. And so I think we need to be careful when we talk about the survivability of these trials, specifically because these trials are also cherry picking the healthiest kids, right? They have to have a performance score. They can't be too debilitated. They can't have metastasized. So you're hitting all these things, but we're selectively super selecting these patients who are less sick, who are likely going to survive a little bit longer. And so I think we need to be really careful when you look into those things. And that's where we need really good statistics and data. And with only 200 to 300 kids a year with this diagnosis, and to be honest with you, a lot of these parents say, why am I going to put my kid through this? We want the best quality of life. And I can't disagree with them. I really can't disagree with them, because the research that we're going to do is going to hopefully help other children, but it won't help their child.
Nice talk, Toba. I was going to ask you, so I read some of those papers on the risk of brainstem biopsy, because we had a family friend in Montreal who was an adult who had a brainstem tumor that looked like a malignant glioma. Ultimately, they decided against the biopsy. I read those papers that you cited, and my interpretation was that, it was relatively safe to do. And you described how there have been swings in attitudes amongst the pediatric neurosurgeons to do it, then to not do it, and then to do it. So today, where do we stand, and what do you recommend when you see a patient with a new diagnosis? Do you say, don't do the biopsy? You say, do the biopsy? What do you tell them?
So, unfortunately, I've been, at least 10 times a year, I have this conversation. So if these children have metastases anywhere else, I've gone after those to preclude going into the brainstem. I've definitely biopsied the brainstem, but the family needs to tell me that they want to be enrolled in clinical trial. Because I don't think if you have the classic triad of symptoms and the imaging findings, then I think it's really hard for me just to do a biopsy to prove to them this is what the diagnosis is, when we can see what the clinical course is. But if they tell me we're 100% definitely committing ourselves to going to a clinical trial, and we talk about it, I get the oncologists involved. I call up Dr. Manji, I call up the guys in Seattle who I trained with. And we have this conversation so that if they do want a biopsy, we are going to enroll them in a clinical trial. So I don't feel like I've done this for just doing it, if that makes sense. So I have conversations with the families. It is fairly safe in the sense of, I've done a couple and I haven't had any problems. We did one here though, and that was that one patient that was in that trial that developed a hemorrhage and then died 2 weeks later. So that was our patient at our institution. So I think that, it's relatively safe, but it's a very high risk profile. These families are already devastated. So we have a very thorough conversation with them. And if they're not going to be enrolled in a clinical trial, I really sway them away from the biopsy, because I don't think the risk benefit ratio is worth it.
I think that's pretty true. I mean, I think there are some places that don't biopsy at all. And then I think there are a lot of places who offer it as an option, but I think very few people really push it, because most of us have gotten sort of frustrated that it doesn't really change the standard of care afterwards. We always say, oh, maybe we'll pull out something weak that has a treatable target, and then we don't usually. But I think the clinical trials are moving more in the direction of including biopsy in the trials. So I think there may be more biopsies done through trials, but potentially less as just part of routine care. Mark's trial, I think in part avoided biopsy because of the concern that that could disrupt the convection enhanced delivery. So that's something that has to be considered too, depending on the mechanism of the trial. The biopsy could impact that if it's CED.
All right, well, thank you everybody for your time. I hope I kept everybody awake today. So, all right, have a great day, guys.
Okay, thank you so much, Toba. Fantastic talk. Next, I'd like to introduce our next speaker this morning. We have a guest Grand Rounds talk today from Dr. Moliterno from Yale University. Very, very excited about her talk. She's coming to us from Yale, where she's the Chief of Neurosurgical Oncology, Director of the Neurosurgical Oncology Program, and also of the Brain Tumor Center. She's also the Director of their Fellowship Program. She did her undergrad at UF, so she's familiar with our areas down here in Florida. Then she went to Yale for training for neurosurgery and then did a fellowship at Sloan Kettering. She has an extremely busy practice, the busiest in Connecticut, doing benign, malignant, and skull-based tumors. And she has a lab which is focused on genomics and precision medicine and brain tumors. And she's just done some phenomenal work with meningioma genomics, which is what she's going to talk to us today about. And so we're very lucky to have her. Thank you so much, Jennifer, for taking the time out to talk to us.
Hi, can you hear me okay?
Yes, that's great. Thanks.
Thanks so much, Mike, and thank you all for having me. It's really wonderful to be here. I only wish I was there in person in South Florida. So I will start by sharing my screen.
Can you go on top on display? Yeah, you
Yep,
go.
I did.
Thank
Thank you so
you.
much. Appreciate it. Okay, so wonderful to be here again. Thank you so much. And I'm going to talk about some of the work that we've been doing focusing on the clinical implications of genomics of meningiomas. I have one disclosure that's not relevant. So meningiomas are a really interesting tumor, at least to me, in the sense that I've asked these questions. Is there really a such thing as a benign meningioma? How does the underlying tumor biology affect clinical behavior, recurrence, and survival? And really what we see in all of our practices, why do some low-grade meningiomas behave more like higher-grade tumors? This is an example of a patient who initially presented to another neurosurgeon in 2015. You can see a convexity meningioma over here. Actually, I'm sorry, the 2015 scan I don't have, but there was a convexity meningioma. And he underwent a gross total resection for that tumor. He was told that it was benign, WHO grade 1. And then in 2017, he presents with this scan, with this tumor, some edema. He sought various opinions, not by me at the time, and ended up undergoing gamma knife radiosurgery for this tumor. 2 years later, it grew. At that point, he was wheelchair bound with intractable seizures, significant weakness, and then was referred over to me. I performed a gross total resection on him. His weakness improved, his seizures dissipated. But the question that I had was, could this have been better predicted and managed differently the first time? This is another example of a 58-year-old gentleman who initially presented in 2014. I don't have his initial films either, but he had a very large frontal meningioma. This is the postoperative scan where they cranialized his sinus. He was told this was grade 1, this was benign. He was quote unquote lost to follow-up, and then represented with this to his neurosurgeon. He was then referred to me for the first time. We did an extensive resection. This is Mike Alperovich, who's a really talented plastics reconstructive surgeon who used a piece of his abdominal muscle to seal off the continuation with the sinus, which the chief of ENT, Ben Judson, assisted with as well. And so my question again was, could this have been better diagnosed and treated and managed differently the first time? And then here is not an example of a recurrent tumor, but an incidental finding of a patient who presented to me. She works at another hospital in Connecticut, has this foramen magnum meningioma that you can see, encasement of the vertebral artery. We took her to surgery, and obviously with the intimate and intricate association with the tumor and the lower cranial nerves and the medulla and the vertebral artery, and this is not a benign surgery and a benign tumor from that perspective. So these tumors, again, whether they're recurrent and more aggressive in their behavior or even not, they can really pose issues and problems for patients. And so the last decade or so has really afforded us a great understanding of the genomic landscape of meningioma, as well as the epigenomic landscape too. And so this is a busy slide, I understand, but I'm going to go through it with you. And so we now understand about 80% of somatic mutations underlying about 80% of sporadic meningioma. And so here, the vast majority of the mutations underlying meningioma are Nf2 mutations. And so this is on this side of the diagram. These Nf2 mutant tumors can co-occur with a SMARCB1 co-mutation, which is a SWE/SNP transcription factor. I'll speak a little bit more on the next slide about, or they can also have chromosomal instability with a TERT promoter mutation, and this can lead to aggressive meningioma formation. The other half of meningiomas, and again, these are sporadic meningiomas, have somatic mutations most commonly in TRAF7. TRAF7 is a gene that was new for its implication in neoplasia when this first came out in science in 2013. And these typically co-occur with a recurrent mutation in KLF4, which is one of the 4 Yamanaka factors, or it can co-occur with mutations in the PI3 kinase signaling pathway, most commonly AKT1. The second most common mutations that are non-Nf2 for sporadic meningioma are involved the hedgehog signaling pathway. These are small mutations, or SUFU, which is a tumor suppressor gene, and inactivating mutations. And then more recently, polar 2A mutations have been implicated in meningioma, and then SMARCE1 over here, another SWE/SNP transcription factor gene, which has been implicated in clear cell as well as spinal meningiomas. When I was a fellow at Sloan Kettering, we were interested in understanding more aggressive types of meningiomas clinically, and we reported in Journal of Neurosurgery that just like gliomas, meningiomas can occur either de novo as more aggressive meningiomas, or they could occur progressive from a low grade to a high grade. Murat Genel and his lab understood this from a scientific, a basic science perspective, in that the majority of these tumors have an Nf2 mutation. They go on to acquire either chromosomal instability or SMARCB1 co-mutation at that time. This leads to hypermethylation, decreased differentiation, increased proliferation, and a de novo atypical meningioma. So it starts out being grade 2. This is as opposed to those Nf2 mutated tumors that harbor a TERT promoter mutation. And those are ones that progress from low grade to high grade. So genomically speaking, we can tell the difference between a low grade and a high grade meningioma. More recently, what I have really focused on is understanding the correlations of these genomic subgroups with the clinical outcomes. And so in one of our studies in JNS, we looked at 3,000 meningioma samples, and we looked at a whole host of clinical outcomes and data. One of the things that we first reported back in 2013, which I really led the effort for in the science paper, was understanding the location of the subgroups relative to the intracranial location based on MRI. And so the way I tend to think about this is that with Nf2 mutant tumors, they're typically lateral and they occur along the convexity. They're typically posterior to the coronal suture, whereas when they co-occur with mutations in SMARCB1, they might occur more midline and anterior to the coronal suture. The TRAF7 alone or co-mutated with KLF4 or molecules in the PI3 kinase signaling pathway, these are ones that we tend to think occur along the sphenoid wing and along the middle fossa, and I'll get to that a little bit more in a little bit. Hedgehog, as I'm sure you're all familiar with, really have that location along the olfactory groove. And that relates to the embryological development and the function of the hedgehog signaling pathway and that development of the brain. And issues with the hedgehog signaling pathway in embryogenesis can lead to holoprosencephaly. Polar 2A mutant tumors typically occur along the sella. They can dip down into the clivus and they can extend out in the CP angles. And then again, just reminding us that there's about 20% of meningiomas that are still mutation unknown. So some of this that I'm going to talk about is known and others have shown, certainly some of it we have shown before, but this is a good summary, again, based on 3,000 meningiomas. So Nf2 mutant tumors, more common in males. These tend to be the largest of presentation, along with those big olfactory group hedgehog signaling mutant tumors. They typically present in older patients, and they're more likely to undergo preoperative radiation. Nf2 and SMARCB1 mutations, not surprisingly, given what we know about the aggressive pathway to meningioma formation, to more aggressive meningioma formation, they typically are associated with higher grade and elevated Ki67. KLF4 mutant tumors are more common in females. As you may know, these are associated with secretory histology and increased edema. They also present later than others. And then the Polar 2A mutant tumors really tend to be the most benign that we see in terms of their clinical features. They have the least amount of edema. They present the earliest, presumably, and most notably because of their association or proximity to the sella or to the visual apparatus. And in our cohort, they were all grade 1. So more recently, we looked specifically at different types of meningiomas based on their location as well as their genomic profile. And so sphenoid wing meningiomas, as this group is obviously has a ton of experience with, we can see that they have varying degrees of bony involvement with the sphenoid bone. And so right here, you can see, here's the intracranial tumor, and then that sphenoid wing involvement. And our question was, how do these tumors differ potentially biologically when you see frank invasion of tumor into the bone versus when you see this subset of these sphenoorbital tumors with that really frank hyperostosis? So we looked at 64 patients who had sphenoid wing meningiomas. As is the case at Yale, all of our patients undergo whole exome sequencing. All of their tissue, I should say, undergoes whole exome sequencing. All patients had undergone my standard approach, which is arterial craniotomy, and then aggressive removal of the sphenoid wing, first by LXL and then drilling down with an M8 drill bit. For these sphenoorbital tumors, or ones that really have that orbital involvement with the proptosis that you see in this patient here, I usually will enlist a multidisciplinary team with oculoplastics and plastics and ENT specialists to really debulk that orbit, as you can see, and then reconstruct it, which has a nice result in terms of the proptosis even immediately after surgery. What we did was classify the bony involvement. And so this is our figure that was actually published in the Journal of Neuro-Oncology recently and featured on the cover. And so this here, you can see type 1, this is no bony involvement. You can see this is the intracranial meningioma, which you can appreciate more so on the MRI than the CT, but there's really no involvement of that bone. We define type 2 as hyperostosis only. So again, here's the intracranial tumor, and then the associated bony overgrowth, which again, hyperostosis only. Type 3, you can appreciate that there's actually not much of an intracranial tumor here, but there is the infiltration and the invasion of frank tumor into the bone, and you can appreciate that on CT. And then type 4, we defined as a combination of invasion of frank tumor as well as hyperostosis. We then classified a subset of sphenoorbital meningiomas here, as I had shown before, really that bony overgrowth with that significant bowing into the orbit. And what we did was we used the contralateral sphenoid wing bone for comparison. So this was something that could be easily represented and used in clinical practice. So not surprisingly, looking at the genomic characteristics for these tumors, as we had seen previously, most sphenoid wing meningiomas harbor a TRAF7 mutation, and that was most common, followed by Nf2 mutation. About 3/4 of sphenoid wing meningiomas have bone involvement. When we looked at the correlations between bone involvement and other patient or tumor characteristics, we found tumors with invasion were more likely to be higher grade, and they were more likely to be larger. When we look specifically at those sphenoorbital meningiomas, we found them in about 14% of patients. Most of them, the vast majority, were classified as hyperostotic only, which is the example that I showed. And these were exclusively seen in women, and not surprisingly, patients who presented with proptosis. When we looked at genomic subgroups and bone invasion, Nf2 mutant sphenoid wing meningiomas were more likely to have bone invasion, older age at surgery, larger tumor volume, while the TRAF7 mutant tumors were more likely to be associated with hyperostosis and smaller tumor volume. And this is a representative image of the pathology correlation. And so this is what you see, sorry, my mouse. What you see in A is an Nf2 mutant tumor with a frank tumor invading into the bone and the sphenoid wing bone. And then B is associated and representative of a TRAF7 mutant tumor with just that bony hyperostosis. Compared to non-TRAF7 mutated tumors with regards to sphenoorbital tumors, those with TRAF7 mutations had a higher percentage of sphenoorbital. This was marginally significant, likely because of the small numbers. Sphenoorbital meningiomas was a strong predictor of TRAF7 alone, and this became stronger when we adjusted for other predictors of TRAF7 alone, which is something that I might touch upon a little bit later. When we looked at the ROC curve for predicting Nf2 and TRAF7 mutations using multivariate models, we found that tumors with invasion were nearly 30 times more likely to harbor Nf2 mutations, adjusting for age at the time of surgery and tumor volume, whereas hyperostosis were over 4 times more likely to have TRAF7 mutations. And so what we concluded was that tumor invasion correlates with Nf2 mutation as well as higher grade meningiomas. This is important, obviously, for preoperative planning, as most of the time we really cannot secure the diagnosis of a higher grade tumor, certainly not an Nf2 mutant tumor on frozen diagnosis. And so when we see sphenoid wing meningiomas, there's frank tumor invasion. This should really be a sign and a clue that we're likely dealing with a higher grade meningioma. And so advocating for a complete resection is important there. And then hyperostosis is more likely to be seen with TRAF7 mutant meningiomas. This is something that we're currently studying in the lab to understand the significance. Why is the TRAF7 mutation or something in that relates to that associated with bony overgrowth? And still, aggressive surgery is important here, but this is more aimed at the bony decompression and relief of the associated symptoms. Switching gears a little bit, another area of interest to us was seizures and meningiomas. And so it's been reported in the literature quite common that patients with meningiomas suffer from seizures. This is less intuitive, obviously, than it might be with interaxial tumors. And so we sought to understand how the biology might affect this. We reviewed the clinical and whole exome sequencing data for about 400 patients who were surgically treated here for meningioma. We found that about 17% of patients presented with preoperative seizures. In univariate analysis, patients with preoperative seizures were more likely to have tumors with higher grade, atypical histology, elevated Ki67, non-skull-based, more convexity location, edema, brain invasion. And here for the first time, we found that these were more commonly seen in Nf2 mutant tumors. When we looked at multivariate analysis, we found that patients with preoperative seizures were more likely to have tumors with edema and atypical histology, but here the Nf2 mutation just approached significance. When we sought to understand that a little bit better, we performed mediation analysis, and what we found was that the direct effect of Nf2 subgroup on preoperative seizures was not significant. However, this effect was mediated by atypical histology, which was then significant through edema in the brain, which then led to preoperative seizures. So not surprisingly, the Nf2 mutation itself is not sufficient enough to drive seizure occurrence, but rather its association with higher grade features. When we looked at postoperative seizures, seizure freedom was achieved in 83%. We actually found that the preoperative empiric loading of an anti-epileptic made no difference in terms of patients who experienced postoperative seizure. So that I thought was interesting and had been reported before. But here we found that irrespective of extent of resection in multivariate analysis, postoperative seizure patients were more likely to have edema, recurrent tumors, and postoperative radiation. When we looked at progression-free survival, we found that patients with preoperative seizures, which is in A, had significantly worse progression-free survival compared to those with without preoperative seizures. And while the progression-free survival did not differ between those with and without postoperative seizures, which is in B. And so what we concluded was that patients with meningiomas who present with seizures may indeed have a more aggressive meningioma, and they may experience a more complicated clinical course with higher recurrence risk. And so more work is needed to be done in terms of the effect, biologically speaking, of Nf2, but it's safe to say that when a patient presents with seizure, we are likely to be dealing with something that's more aggressive. In the last story that I wanted to present to you this morning was a study that we had published in Neuro-Oncology last year, looking at the outcome data for 469 meningiomas. This was the first study to identify molecular subgroup as an independent predictor of recurrence, along with grade and prior recurrence. Specifically, we found an overall rate of recurrence at 2 years was 12%. This was 7% for low-grade tumors, and higher-grade lesions was, of course, higher at 33%. For the first time here, and what was really the take-home from this work, was that we found 4 subgroups had appreciable rates of uncensored recurrence at 2 years. And so those tumors that had mutations in Nf2, TRAF7, and molecules involved with the hedgehog or PI3 kinase signaling pathways were more likely to recur at 2 years. The more quiescent subgroups we defined as KLF4, POLR2A, and SMARCB1 had only 1 recurrence. What was interesting here was that we didn't expect SMARCB1 from everything I told you before about being along the pathway to aggressive meningioma. We didn't expect SMARCB1 to be in the more quiescent group. When we did further analysis, we found that really those tumors all underwent gross total resection, and they had a greater extent of resection, probably due to their location being more anterior along the sinus and along the falx. Nonetheless, we found that there is a difference, a 22 times higher rate of recurrence with those more aggressive meningiomas that I mentioned. And this held true even when we considered the lower grade tumors. When we looked at the aggressive subtypes further, at 60 months, the hedgehog Nf2 TRAF7 meningiomas continued to exhibit elevated rates of recurrence. What was interesting in the take-home from this figure were the PI3 kinase mutant tumors. And so most of those tumors recurred within the first 24 months, even in low-grade samples. And remember, those are the ones that tend to occur along the sphenoid wing. When we looked even further, we found that the polar 2A mutant meningiomas, which are arguably very rare, the mutation itself showed several recurrences that were at later time points. There were only 3, but that's something certainly that we need to look at a little bit further as we continue to follow these patients. The PI3 kinase mutant tumors recurred earlier, polar 2A later, and then the others, hedgehog Nf2 and Nf7 mutant meningiomas, really just had that steady rate of increased recurrence over time. And we found similar rates of recurrence when we looked at the molecules themselves, so there was no difference within the molecules that were mutated within the PI3 kinase and the hedgehog signaling pathway. When we looked at low-grade meningioma recurrence specifically, here we found it interesting with an elevated recurrence of low-grade samples, of course, was associated with subtotal resection. That was not too surprising. But what was interesting was the association with hedgehog as well as Nf7. So again, this brings up the question when you have those large olfactory groove meningiomas, and there's a little bit of tumor or hyperostosis that's left at the skull base, what do we do with that? And how aggressive should we be with removing that tumor? And it seems as though we likely should be. In univariate analysis with progression-free survival, not surprisingly, as you can see in this figure as well, there were significant negative associations with higher grade, non-midline locations, so again, being more lateral and along the convexity, atypical histology and features, elevated Ki-67, previous recurrence, and then the protective associations were with gross total resection and female sex. Here we found Nf2 mutant meningiomas were negatively associated with progression-free survival, while KLF4 meningiomas were positively associated. When we looked in multivariate analysis, grade and prior recurrence, not surprisingly, were identified as significant covariates. And similar to the seizure study, we found that amongst the genomic subgroups, the Nf2 samples were not observed to be an independent factor associated with progression-free survival. So again, similar to seizure, the Nf2 mutation itself is not enough to drive the poor survival, but rather its association with the high-grade features. And so going back to the examples that I showed earlier, could this have been predicted and could this have been managed differently in terms of this patient? And the answer is yes. And so first of all, this is an example of the reports that we receive on all of our patients here at Yale. And so it's an integrated diagnosis. First of all, the histology itself came back to be an atypical meningioma, grade 2. But then when we looked at the whole exome sequencing data, we found down here, you can see there's an Nf2 mutation, which makes sense. It's a convexity meningioma. He had presented, he had had seizure. And then you can also see here the chromosomal instability. So a lot to do with various deletions and amplifications of the genome, particularly chromosome 1p deletion. So based on what I discussed earlier in terms of the pathway to more aggressive meningioma, this is an Nf2 mutant tumor that does not have a SMARCB1 co-mutation, does have chromosomal instability, and that would be a de novo atypical meningioma. And so what we learned from the genomic data was that this tumor was an atypical meningioma when he initially presented. And that was something that was likely missed based on histological diagnosis at the community hospital. And so this once again underscores the importance of an integrated diagnosis. In our hands, this patient would have been radiated after his initial surgery. This is another complex patient who was initially managed by one of my partners in 2017, had this large sphenoid wing meningioma, a 70-year-old woman who presented with vision loss in her left eye. She underwent a near total resection, leaving a small amount of tumor in her sella to preserve function. It was histologically WHO grade 1. This is her post-op scan in January of 2018. A few months later, not very many, 5 months later, you can see progression of her tumor. And so this would be, of course, highly unusual that we would consider for a WHO grade 1. And then she underwent radiation, and then she subsequently had a scan in October of 2020. Since then, she's undergone 2 additional surgeries. She's had additional radiation with gamma knife to the cavity, and she's being considered for clinical trial with immunotherapy. And so the question that I had, even with those subsequent surgeries, she's always had this report, which is the, again, integrated diagnosis of meningioma, WHO grade 1. It has stayed the same, WHO grade 1, but here we can see the AKT1 mutation. And so not surprisingly, based on what we reported in neuro-oncology, when she had that early recurrence, earlier than 24 months, this would be a clue to us if we didn't have the whole exome sequencing data, that we would be concerned for that AKT1 mutation underlying. And this is probably somebody who with that knowledge up front, we might consider earlier radiation to that small residual. This is another complicated patient, 50-year-old woman who presented initially in 2006 to another hospital, to another surgeon, worsening gait, left-sided weakness, had a large sphenoid wing meningioma. She underwent several resections, several rounds of radiotherapy, and then began the Pember trial with Priscilla Brastianos at MGH in 2019. She failed with this scan here in 2020. Priscilla kindly referred her to me for surgical resection. You can see really vascular, nasty tumor. This is her post-op scan. She did beautifully with surgery. And once again, we're dealing with a WHO grade 1 AKT mutated tumor with this chromosomal instability, most notably chromosome 1p deletion. And so again, another great example of how these benign tumors are not so benign. And then in a final example, this is a patient with multiple meningiomas, and that's something that we are actually submitting for publication now. That's an interesting story as well, where this particular patient had these 2 meningiomas. You can see the one on the left side, this sphenoid wing region, had some associated edema, so I ended up resecting that one. This is his post-op scan. This is his anatomy, actually. And this came back with our integrated diagnosis, WHO grade 1. And then you can see that the TRAF7 AKT1 co-mutation. So the question here is what to do. First of all, what are the implications for the other tumor, which again is something that we have some more insight into, but also what to do in terms of treating this patient. Do we follow him closer than we might another WHO grade 1 tumor? I would say yes, for sure, with that AKT1 mutation. And do we consider upfront radiation? I think that's where we really need further clinical trials to understand that. And so I'm sure just like you guys there, we have not only our multidisciplinary tumor board, which I direct, but also our precision brain tumor treatment program. And that's really important. Each week we discuss our patients based on the integrated diagnosis, using the whole exome sequencing data, and particularly in meningiomas, we find it incredibly helpful. So in summary, and I apologize, I'm ending a little bit early because I have a trans lab that is going on, so I have to run to the OR in a little bit. But in summary, there's no such thing as a benign meningioma, in my opinion. You clearly cannot just rely on histology to guide treatment. I didn't even touch upon the epigenomics work, and so the work with methylation data and other incredible studies that have been most notably coming out of Toronto recently and published recently. Understanding the genomics and epigenomics, I believe, is really what's going to help guide the management, particularly of meningiomas and these more difficult to treat meningiomas. But again, more work is needed, more trials are needed. I just wanted to acknowledge my team. and not everybody is pictured here, but all of the people who contributed to these studies, my lab, Murat's lab, and these are my nurse practitioners and my nurses who are part of our Susan Barris Yale primary neurosurgical oncology program. This is my fellow Neelan. These are two of my research associates. This is my scrub tech Larry, who scrubs on all my cases and makes my life so much easier. So thank you to all of them. And thank you to all of you for having me this morning.
Thank you so much, Jennifer. That was a fantastic talk. I had a couple of quick questions for you. One was, so the integrated genomic panel, is that something that you're doing in the house, or is that something that you're doing as a next-gen sequencing and you're just pulling out the specific sequences that you're looking for, or is that done in your lab?
That's something we do in-house. And so we're fortunate in that our hospital funds all of that. And so it's whole exome sequencing, not targeted sequencing. So we have a huge amount of information that we receive from that. It takes us a couple of weeks for the information, which sometimes can be a little bit frustrating. But typically the turnaround is not too bad. And again, gives us a lot of information, and then we behind the scenes will look into it and kind of have, taper that down, and then we'll discuss what we come up with as relevant at the Precision Brain Tumor Board.
And I was wondering, for the hyperostosis subgroups or genomic findings, there was a paper out of UCSF that came out recently looking at how heterogeneous some of the areas of meningiomas are, and how you could actually see sometimes when you have progression of disease in the posterior aspect of meningioma and the anterior part is not really growing, there is changes in the mutation status. So I was wondering, in those mutations that you looked at for the different bony invasions, were those samples taken from the bone or from the soft tissue, or and would you expect there to be any changes at that interface?
Yeah, so both they were taken from, and as the study really started because of what I started to see clinically in my practice. I just happened to notice that the ones that had a lot of bony overgrowth seemed to be TRAF7 mutated. And then, the ones that were more invasive were Nf2. So we started kind of retrospectively looking into it. And then now that we've established that, we've taken much more care with doing exactly what you're saying. And so even doing spatial sequencing to understand how from one location of the tumor to another, the mutations can vary. So that's something that we're currently looking at. The other thing that's tricky and hard as well, as I'm sure you guys do too, sometimes that hyperostosis is difficult to bite off. And so a lot of times I would rely on just drilling it down, but then you lose the bone for that. So I've been a lot more conscientious in trying to save that bone too.
Yeah, no, definitely. The bony area is very hard to kind of sequence. So yeah, that's very interesting. Thank you so much again. Anybody else have any questions? Okay, great. So, well, we know we have to run. So thank you for your time. Good luck on your case today. And we're hoping that you can come down here to Miami and visit us in person sometime soon.
I would love it. Thank you so much. It's great to see all of you.
Okay, take care.
You too. Bye.